See, I was supposed to debate, and I've got a walkover, so I don't think I'll be really debating, and I'll be just talking. No, it's not moving. Not this. Yeah, this one. Yeah, that's fine. So actually, the debate was between these two procedures, which I think are totally different procedures that you can't really compare them. And if you look at them 24 hours down the line, they are totally different. The miseries which the patient has to undergo, I think it is totally different. And it was in mid-90s when we used to debate between surgery and medical treatment, and that time I had started to do PCIs in the left main, and when PCI was class 3 contraindicated, I was busy doing CTOs of the left main. So I've been in this business for quite some time. This was a CTO of left main which we corrected, and then 2 decades down the line the patient is okay. I think it was quite a long period for the angioplaster to wait before they could get any nod from the regulatories and finally find a place in the guidelines. But these guidelines came after the syntax trial, and in the syntax it was only a subgroup of left main. So the doubt was that whether head-to-head comparison in surgery, with surgery in left main alone can be done or not, and does it really do well or not. So 2 big trials came. One was a Nobel trial, which was about 1,000 patients, and the other was Excel. And often we keep talking about Nobel is negative for PCI and Excel is positive for PCI, and I really don't think it is. I think both are in the same line. The only difference is that Nobel, smaller number of cases use a different kind of stent, but had an inclusion of repeat revascularization as endpoints. The other hard endpoints like death, MI and stroke, they were there, but they also included repeat revascularization. And Nobel found that you have to do more PCIs again if you do PCI 1 compared to surgery. On the contrary, Excel had a wrong, I think, according to me, wrong endpoint. That was a peri-procedural MI which was diagnosed on the basis of only enzymes, which was not really clinically relevant. But Excel also showed that death, MI and strokes 3 years down the line, they were more or less the same. And then came a big IPD meta-analysis which showed that if there is no diabetes, no difference. Left main, no difference. The difference is mainly if you have multivessel disease. Also, the difference is exaggerated if you have a diabetes. And hence, some change in the guidelines, and you find that left main finds its place in the guidelines not as a weak entry, but it's as a strong entry, especially if the syntax score is less. That means the anatomy is relatively simple. If the syntax is less than 22, it is class 1 indication. And to my mind, an osteo left main and a body of left main, I think it has all the advantages of doing PCI compared to surgery. So it scores over surgery for ostium and for left main stem. However, as the complexity increases, you go to bifurcation and you start adding CTOs, bifurcations, and other coronary artery downstream lesions, then of course it is the bypass surgery which wins. Syntax 5 years down the line has shown that if the score is less than 32, you're good with PCI, and the score is more than 32, you're good with surgery. But one thing, just to remind, that syntax had used Texas stent, which is paclitaxel, and it has been shown in the French left main registry that if you're using paclitaxel compared to limus, it is significantly inferior. And but 10 years down the line, even Texas has done well. So if the Texas does well head to head as is surgery, there is no reason for a limus not to do as well compared to the surgery. 10 years down the line, all cause deaths in different groups of syntax. If you find this, if the syntax score is high, only then you find a difference. Otherwise, the difference is not much. There is more than 65 meta-analysis on this topic. Many of them done previously, but I think large number of them done after the Excel and Nobel. And in today's day and age, I think this is a wasteful exercise. It is wasteful because it is occupying too much of space in the journals. Same thing, same topic, same findings. You see 7 meta-analysis published in American Journal of Cardiology. Same findings. And if you know that meta-analysis is with problems about inclusion, procedures, follow-up and definitions. If you look at this, different timings about meta-analysis, starting from Lehman's to this, and different inclusion criteria like diabetes and number of the lesions and syntax scoring, and also different kind of stents being used and off pump and bilateral internal memory being used. And also even the outcome definitions are different. So probably you cannot fully apply them. But if you want to really draw out an inference out of so many meta-analysis, for me the inference is, as far as death, stroke and MI is concerned, score is 1:1. Both are equal. As far as spontaneous MI is concerned, they are more with PCI, repeat revascularization more with PCI. And if you look at the MACA as such, definitely it has to be more with PCI. So let me just skip some of the slides and come close to the conclusions. This one good paper, that if you have isolated left main and just single vessel disease, you have all the advantages of PCI, all the advantages of PCI over surgery. So simpler lesions, low syntax score, or left main with just single vessel disease, this PCI scores over surgery. So now the guidelines say that if you have a left main disease, you go about the syntaxing, and if surgery is same, it's class 1 indication for all of them. But if the syntax is less than 22, this gets a good 1A indication. If it is 23 to 32, it becomes 2A, level of evidence again is A. But today's guidelines, they forbid you from doing an angioplasty if the syntax is more than 3. Despite the fact, significant proportion of patients who are in the Excel had a syntax score more than 32. And when you talk about guidelines, whatever is the attendance, many of them, they are like this. So I think let me just give you take-homes. I think take-homes says that you have a comparable survival stroke and MI, repeat revascularization is higher except at the ostium in the shaft. Despite higher syntax score, the results are not so bad at left main. High syntax score distally with multivessel disease does much worse than at the left main. And PCI in the low and intermediate syntax score does as good as the CABG and as bypass surgery. So I'll say finally it should not be really a debate. We should do a so-called shared decision making where we should look at the clinical factors. If it's an urgent revascularization, and well, PCIs can be easily available. If there is a serious comorbidity and there is high surgical risk in the form of chronic lung disease and many other comorbidities, then I think PCI scores over. On the contrary, if the ejection fraction is low and there is long-standing diabetes, especially insulin-requiring diabetes, and there is a need for a concomitant cardiac surgery, and also there is something to prevent you from taking diabetes. So that tells you that these patients should be taken up for surgery. And coming to anatomical factors, if it is ostium and left main stem, I think good go for stenting. But once you go to bifurcation, trifurcation and multiple CTOs, I think you should think many times before you want to jump on to do an angioplasty in such a case, because surgery gives you very good and long-term results. And if you have a significant downstream multivessel disease and you have a complex anatomy, then I think these patients should go for surgery. But one word of caution, nowadays with so many comorbidities, surgeons have problem. Surgeons will say no, because they know that if these comorbidities are there, then the mortality is almost 600%. So the cardiologist will have to handle many of these patients with so many comorbidities. In the real world, we see that the number of angioplasties is increasing and the number of surgeries is decreasing. So I think it is a good time that we should shake hand. In fact, surgeons should shake hand more because their number is decreasing. It is not only for them. I think final decision making has to be given to the patient. If you say that major endpoints are same, then I think it's the shared decision making has to be mainly vetoed by a patient. And I'm sure even a surgeon will not like to go into the theatre. Thank you very much.
Any comment? I think it's very important that many of the cases which are used by the surgeon now are being done by the cardiologist as a bailout or as a palliative 1 or 2 SL like that, and the rest on a medical treatment. So that is a new approach. In India, basically this approach has become now more because of reduction of the cost of angioplasty and stents. there was a cost were higher. Nowadays, even critical vessel in some time, left main, you do something and
Just single crossover stent and yeah.
there is a which save the life of the patient.
IVUS or OCT is a mandatory?
I think at least in the beginning of somebody's career, I will say if not mandatory, it is prudent to have some kind of training to compare angiogram with IVUS, because in my training about a couple of decades ago, I realized that the sizing which you do with an angiogram often is undersized, and you end up in many times suboptimal results. Many of the conferences when people are showing that it was like this, so I did IVUS. I told him, why did you do IVUS? Even angio is showing suboptimal result. I will say in the beginning of the career, it is very important to have IVUS, but otherwise, because IVUS adds to the cost, not to the procedural complications, because procedurally I think it's just like passing a balloon over it. But I think cost is an important factor, we cannot just ignore it. But in my practice, if you ask me, I use IVUS maybe only in 2-3% patients when I'm doing left main. But earlier in my career, I used to do in many of them. And if somebody wants to start it, I'll say it is much better to at least have taste in some cases, maybe 15-20 cases, so that you know as to what is the meaning of this kind of an angiophania. OCT might have an advantage, especially if you want to do double two stent technique, especially if you want to really know as to where your wire is passing through the cell, proximal or distal cell. Otherwise, I think IVUS tells you probably as much. As far as clinical information is concerned, it gives you enough clinical information. Of course, OCT is like a 10 megapixel compared to 1 megapixel. Pictures are very good, but if you're able to identify from shadows, you don't really need clear pictures.
Thank you very much, sir, for the lovely talk.